started. Welcome everyone. My name is Shirley and I'm going to be your moderator tonight. This evening's webinar is How I Treat Early Caries with Curodont. I am excited to welcome Dr. Gavin Miller, who brings extensive experience, a commitment to advanced care, and has been recognized as one of San Diego's top dentists. We also have Dara Flores, registered dental hygienist and oral science liaison for Vivardis, here to answer any technical questions tonight. Before we get started, I would like to take a moment to go over some quick housekeeping. If you have a question, please go ahead and type it into the Q&A box and type it in as it's coming up for you. And we're going to address them, all the questions, at the end of the webinar tonight, but go ahead and enter them as they're coming up. CE is not available for this webinar, and everyone who registered, you'll be getting a link to tonight's presentation sometime over the coming week. Okay, so without further ado, I'm going to go ahead and welcome Dr. Miller and Dara. Thank you so much, guys, for being with us tonight, and I'm going to pass it over to you now.
Okay, thank you, Shirley, for that warm welcome. And thank you all our participants for joining. My name is Gavin Miller, and like most of you, I'm a practicing restorative dentist. I was born in the beautiful city of Cape Town, South Africa, at the southern tip of the continent of Africa. Moved to Johannesburg at a very young age and basically grew up there. I graduated Wits Dental School in 1986, a long, long time ago, and was one of the lucky ones that was drafted into the army 5 days after graduation. So I basically spent the next 2 years in the military. I then spent 12 years in private practice in Sandton, Johannesburg, and decided to emigrate with my family to San Diego in 1998, and have been practicing dentistry in the La Jolla area ever since. I'm excited to share my experience with Curodont Repair Fluoride Plus and the positive impact its introduction has had on my practice. I've always strived to stay up to date on the newest developments in clinical dentistry, and I'm presenting a product to you that I feel is a game changer, already has been a game changer in my practice, and I think could be for you too. So early incipient lesions, what have we done up until now? We identify and put a lesion on watch. We all know that feeling. We walk into hygiene, have a look at the x-rays, a watch on the mesial of 2 and the distal of 3. And we advise patients basically to brush and floss the area with extra care and leave it until their next recall visit. We hope that they comply and that we get lucky and the lesion does not progress to the point of requiring an invasive procedure. But we know that the vast majority of our patients will not even remember which teeth we pointed out to them by the time they get to their car. And we also know that hope is not a strategy. So we now have the ability to stop the progression of these areas with an over 90% success rate by applying Curodont Repair Fluoride Plus in one quick, easy application, utilizing the process of guided enamel remineralization. So we utilize Curodont in a very efficient manner in our practice. It literally takes 5 minutes to apply, and we then dismiss the patient. When I walk into a hygiene room, my hygienists have already noted the areas that seem like good candidates for Curodont Repair Fluoride Plus. Generally, they're spot on, and all I do is basically reinforce the advantage of treating these areas early as opposed to just watching them and hoping as we used to do. Most of our Curodont applications happen in the hygiene room. We also do a lot of CAD/CAM same-day dentistry in my practice, and any non-cavitated demineralized areas that I see on adjacent, now directly visible teeth, because I've started prepping already, those areas will have Curodont applied while we design and mill the restorations. And that way it involves absolutely no extra chair time. This approach has allowed us to help patients prevent from having extra teeth drilled on and added quite significantly to our practice production and bottom line. So the proprietary technology works by remineralizing the enamel structure all the way to the depth of the lesion and therefore preserving tooth structure. So in our practice, we've been using Curodont for just over 20 months. We've treated more than 1,000 teeth. We have a very high patient acceptance rate once we present it to them. And it's helped significantly with our, as I said, with our practice production and improved our bottom line. So we use treatment code D2991, which is the application of hydroxyapatite regeneration material. Our practice charges $110 a tooth, and it's been a win-win-win. For me personally, and I'm sure I speak for several other dentists out there, I don't particularly get excited seeing a quadrant of multi-surface posterior fillings in my schedule. I think they're time-consuming to do, they're difficult to do well, and I don't think that we're that well remunerated for it. So having a treatment modality that decreases the frequency of these procedures actually frees me up to practice the more impactful dentistry that I enjoy. The hygienists, when my hygienists have actually really improved their diagnostic abilities and are pretty much spot on when they put a lesion on watch and say, you know, let me call Dr. Miller in and see if we'd like to do a Curodont in this area. And they feel more valued. They feel like they're not just cleaning teeth, but they actually are being part of, you know, the preventative side of our practice. So they really get some job satisfaction out of it. The patients win. Basically, the 4 no's are really appreciated by them. No pain, no fear, no injection, and no drill. And the dentists win because, you know, we really get to free ourselves up, as I said, to do more impactful dentistry. And we should see most remineralization on a lesion within 3 to 6 months. In our practice, we've only needed a second application a handful of times, and there's absolutely no contraindication to doing 2 or even more applications. So let's go through the application process. It's actually really, really simple and takes a very short time. So the procedure is simple. We clean the area to treat, and generally speaking, if the patient's in hygiene, that has already been done for us. We etch for 20 seconds, rinse and dry, apply Curodont to the lesion for, I normally tell my hygienist to apply it for 30 seconds, but there's no hard and fast rule. So the only exception for interproximal applications, I normally get them to apply the etch using unwaxed floss and then rinse and dry, and then apply the Curodont by squeezing the sponge from both embrasure spaces, and we'll show you in a video how we do that. The use of a wedge or spacer is not needed because the product has such a low viscosity that it will flow directly into the contact. We leave the area isolated for 5 minutes, and then we dismiss the patient with instructions not to eat or drink for 30 minutes. And at that point, often my hygienists are wanting to apply topical fluoride as well, and there's no contraindication to doing that either. And then, as I said, it generally takes 3 to 6 months for the repair to work. Let's just play this quick video and show you how easy the application of Curodont is. Okay, so there you can see basically it's a really, really simple procedure to do. We've really enjoyed introducing it into our practice. The patients feel, even though it's not it's a fairly low-tech product, I would say, they really feel that, the comment that I often get is, you guys are such a high-tech practice, and we love that you keep up to date with the newest developments and the latest and greatest. And yeah, that basically, Shirley, is the gist of our presentation. Dara, would you like to go through the Curodont Repair Plus promo code?
Yeah, I think Shirley's going to come on and chat about that. Then we'll go over some Q&A.
Okay, that's fine.
Wonderful. Well, thank you so much. That product looks really very exciting and incredible. And while we wait for questions, I wanted to mention that we have an exclusive promotion for tonight's attendees. If you'd like to try Curodont, we are offering 15% off the MSRP on one box of Curodont Repair Fluoride. The promo code, if you're interested, is AAR, and I'll repeat that again. A for Apple, R for Robert. And simply scan the QR code, and then the promo code will automatically be applied. But yeah, that's exclusive for our attendees tonight. And I wanted to let you know that we do have questions that have come in. But Dara, did you want to offer anything else, or should we launch straight into the questions?
Yeah, we can go straight into the questions. Then I'm going to post in the chat as well some resources. Our website is a wealth of information, has additional training and application videos, modules, before and after photos, the complete application process if you want to print them, so as well as marketing materials for your practice. So I will put that in the chat so you guys have access to that easily.
Thank you so much, Dara. And thank you, Dr. Miller, for keeping this page
You're
on
welcome.
so that, yeah, and then we can go ahead. So we've got, I don't know that we'll get to all of these. We have until 8:45 p.m. on the Eastern Coast. I know it's on the Western Coast, it's 5:45 p.m. But I will let you know that we do have about 20 questions that have come in so far, and let me just get started with them. This one is from Katie Blaylock. I need help with 5 minutes of dry time. Does it have to be completely dry for the entire 5 minutes? Also, before you move on to the next tooth, what if it gets wet?
So Dr. Miller, I can pop in here if you're okay with that.
Sure.
So it doesn't have to be completely dry. You just don't want the area that's been treated to become saturated with saliva. So just keep the patient comfortable. Put in a bite block, some cotton rolls, a slow speed suction. And if a little bit of saliva gets in the area, that's okay. We just don't want it to be pooling around the area that's been treated.
Thank you,
Yeah,
Dara.
we found it very useful to use an isolite or a dry shield just to leave the area a little isolated. We haven't had any issues with the patient keeping it dry for that period of time.
Well, thank you, Dr. Miller. This next question from Stephanie Sullivan. If a patient reports strong zings or sensitivity after an application, does this indicate that it's working, or what would cause this sensation?
So I've actually never had that reported to me, interestingly enough.
And yeah, seeing here, Dr. Miller, it's not something that's often or really ever been indicated. So Stephanie, I would love to connect with you on the procedure and see if there's something along that way that may have caused that, but no, Curodont wouldn't cause any zings or sensitivity.
Thank
And like
you.
Dr. Miller said, I don't think he's had any either, so.
No, I haven't. I'm wondering if perhaps it was application of the etchant gel that may have run onto an area of recession or exposed dentin that may have caused the increased sensitivity.
Yeah, I was wondering that too.
Yeah.
Thank you. From Janet Moore, does Curodont come with fluoride?
Yes, it contains 225 parts per million of fluoride.
Great. From Anna Svetlowska, how much to charge for the application, and is it per tooth? How much should one charge per application?
Well, so there's the variation that I've seen in my geographical area is between $100 and $150 per tooth. We started off charging $100, so we started off on the low end. We've bumped it up to $110. We've had absolutely almost no patient pushback. And as I said in the presentation, and I think that's erring on the conservative side, when we present it to the patients, we have, I said, a 90% acceptance rate. Is probably 95%. The one tip that I do have is that I've asked my hygienists when they present it to the patient not to say that it's not covered by your insurance and it's going to be $110. I rather get them to say, that the patient's portion or responsibility is $110 per tooth. I just find that people have such an expectation, especially in Southern California, that if, they expect that if the insurance doesn't cover it, maybe they shouldn't do it. So, but even having said that, when our verbiage probably wasn't as clear when we first started doing it, patients see the value in this product. It's really not very difficult to get them to comply.
Thank you. This next one from Jessica Woods. What method or methods are you using to assess the need for a Curodont application?
So that's a very good question. So we're going off of obviously the clinical exam, because you can apply Curodont to any surface of the tooth. But having said that, I would say that 80% of our applications are in the interproximal area. So of bite wing radiography, we have a Caries view that actually is probably even more diagnostic, which we use as well. But most of it happens off of the bite wing examination.
Thank you, doctor. This one from Janet Moore. How do you know it is working? What do you see on x-rays?
So that's also an excellent question, because we see there's a spectrum of results. So I would consider success in a lesion that doesn't progress any further. Having said that, we have seen lesions get smaller and some of them even completely disappear. I mean, we have the before and after photographs. We show the patients, they're blown away by that. So we have teeth that we've just said to them, listen, at this point, we can take it off a watch completely. There's nothing there to even see. But, going back to your question, I would say that non-progression of the incipient lesion would be, for me, in my practice, would be considered successful.
And I agree with that. It's a great response, Dr. Miller.
Thank you both. This next one from Amit Shah. Can you talk more about how you clean the tooth? The directions say sodium hypochlorite.
So the directions do say sodium hypochlorite, and I'll be totally honest with you, I barely ever use it in my practice. So, and as I said earlier, because most of our application happens in the hygiene room, the teeth have already been cleaned. The only time that I personally, apply Curodont is when I'm prepping teeth and I've exposed the interproximals of the teeth on either side and I see a lesion. And then, we'll just pumice or polish the tooth really quickly and then just apply it. And that's probably the easiest and most accurate application you'll ever have, because you have complete direct exposure to it.
Yeah, and that's just to piggyback on that. The sodium hypochlorite is optional. You can use an air polisher, of course, prophy paste, pumice, as long as you're removing that salivary pellicle. That's what's important. And that can be done with your preferred method.
Thank you. This next one from Hein Kill. Is etching a must? Why etching?
Dara, do you want to handle that?
I can take this one.
Yeah.
So etching removes any inorganic matter that might be blocking the surface layer of the lesion. So etching is an absolute must to make sure that the proprietary formula can penetrate. So don't skip out on the etching. 20 seconds with just a 35 or 37% phosphoric acid, your basic blue etch.
Thank you. This next one from Adrian Hughes. Is it ADA approved?
We are FDA registered. We are not currently ADA approved, but in the process.
This next one from Anna Svetlowska. Do you take a follow-up bite wing in 6 months?
So generally speaking, we take a follow-up bite wing. We take bite wings yearly. We have, especially in the beginning when we started to use this product, we started taking bite wings at the 6-month period just because it was such a new product and I wanted to make sure that I wasn't recommending something that wasn't beneficial. So we did do that. Now that I know that I have full confidence in the material, I do not take a bite wing at 6 months. We stick to the normal protocol that we've always had. Amazing.
This next one from Lori Mills. Does it stain or darken the tooth?
It does not. It has no taste. It doesn't stain the tooth. It doesn't darken the tooth. Those are the big advantages of using this material over some of the other alternatives.
This next question from Cynthia Quint. Can you show the video on how to apply the product one more time?
I did just, yeah, we can play it again. I'm okay with that. But I also just posted our resources page in the chat, which our video is available on our website as well.
Okay, do you want me to quickly play it again? We're good with that?
That's good on our end, if that's okay with you, Dara.
Yeah, of course.
Thank you, Dr. Miller, for showing that again. This next question from Erica Geffert. What is the active ingredient in Curodont that arrests the decay and promotes remineralization?
It has 500 parts per million of sodium fluoride as the active ingredient, along with our proprietary formula that helps drive the remineralization process by pulling in calcium and phosphate and fluoride from the saliva.
Have you had this next question from Melissa McGlynn? Have you had success using around anterior crown margins?
I actually have never used it around anterior crown margins. That's not something that I have ever even thought of trying, to be honest with you. Dara, is there an indication for using it around crown margins?
No, there isn't. It's really indicated for incipient lesions, E1, E2 lesions, those enamel lesions that are not yet cavitated. So,
yeah.
Thank you. This next one from Andrew Eli. Is only one application needed?
So I would say that most of the time that we've used the product, we've only needed one application. The few times that we have needed a second application is occasionally if we feel like we haven't started, we've seen still slight progression in the lesion, we'll try it a second time. And then other times I've had where on X-ray it looks like we have stopped the progression of the lesion and we've explained that to the patient, but we say we can still see it on X-ray. And then some of my patients have asked me, is there any contraindication to using it again just to see if we can actually, reverse it? And that we've done it. There's no contraindication to using it twice or even 3 times.
Thank you, doctor. And this you may have answered, but I'll ask it again just in case you haven't, from Erica Casper. Why is the etch required before application?
So that helps remove any inorganic matter that might be blocking the surface layer of the lesion, just to make sure everything can penetrate properly. So 20 seconds with your phosphoric acid.
This next one from Amber Lingle, is this applied by the dentist or the RDH?
So most of my applications are applied by the RDH. The vast majority of Curodont in my practice happens in the hygiene room.
Thank you. From Mary Bador, can you use it if you have a hard time isolating on young pediatric patients, for example?
You can, and I mean, that's part of the battle that we all have, right? Working on young pediatric patients, doing sealants, doing fillings, and that's not a contraindication. You're going to have to be pretty quick. And in those situations, we've made sure to, to cover the whole area with gauze as well as cotton rolls and just try our best to keep it as isolated as we can. But it certainly hasn't stopped me from using it, even in the difficult pedo patients.
This next one from Joe T. Danielle. If there's gum bleeding, does that affect the outcome? And Viscostat can be used, or the chemical affects the outcome by interaction?
So Viscostat can be used as long as you're etching afterwards. Initially, when we started using the material, we were using wedges to wedge the teeth apart and get better access to the interproximal area, because we just didn't have the understanding then that the material is so flowable that it reaches the area no matter what. So we don't, and we used to get bleeding when that happened. And we don't use or even recommend the use of a wedge any longer. But if there is bleeding in hygiene, there's absolutely no contraindication after using Viscostat to still place it, or even if the hygienist can run a laser there and get some hemostasis if you need to.
That's a great answer, Dr. Miller. Yeah, the biggest thing is you just don't want there to be hemorrhaging right while you're placing it. So like Dr. Miller said, get the bleeding under control, follow your Curodont steps, and you're good to go.
Great, thank you. Do you etch off facial surfaces? From Cindy Hughes.
So if we're treating facial surfaces, we still etch, yes. It's exactly the same procedure for any area of the tooth that you're treating.
You're just etching the lesion,
Yeah.
lesion that you're treating. So you're not placing it all over the entire facial. It's a very targeted treatment and approach.
Yeah.
From Sarah Dowdy, do you charge for the fluoride varnish if they opt for the Curodont?
We actually do. Most of my patients that are getting fluoride treatments in hygiene have been used to getting it anyway, so they're used to that charge. In my mind, and I think most people would agree, they're two completely different treatment modalities, and I have no issue charging for both.
This next one from Hiba El Noor. How do you know when the Curodont has worked? After 3 to 6 months, if the lesion is still there, do you still drill it? What kind of patient would you need to do a second application?
Yeah, so I think we basically touched on that. The only time I would ever pick up a drill for those lesions was if the Curodont didn't work at all and the lesion had extended into the dentin. And the only time I think that would happen was possibly the application wasn't as well done as it should have been, or it was a misdiagnosis and it looked on x-ray like the lesion hadn't penetrated the enamel where it in fact has. And that's where actually using the Caries view for us has been diagnostically very helpful, because then you can really picture the lesion much more accurately, I think, than just on a bite wing. When would we apply it a second time? As I said earlier, if we feel that we haven't stopped the lesion from progressing, or if the patient requests it because we've told them that there has been, we've arrested the progression of the lesion, but we can still see it on X-ray. And sometimes they said, well, is there any harm in doing it a second time? And we say no, and we've treated that again. but it doesn't happen very often.
This one from Allison Arenziak. If you use this in conjunction with guided biofilm therapy, can you skip the bleach step? Guided biofilm therapy removes the pellicle.
Absolutely. Yeah, as long as the pellicle's been removed, you absolutely can. I don't ever use the hypochlorite step.
That's a very effective way to remove the pellicle, so that's
Yeah.
absolutely acceptable.
Okay, and this comment from Nicole Gallegos, the QR did not work for you. Nicole, I just tried it myself and it worked for me. Give it a try again. If that doesn't work, let us know and we'll get you a link. This next question from Shiva Talebi, does this remove decalcifications? Would this work if icon treatment was already done to remove the decalcification?
So it's not, I've found that it's not a replacement for icon treatment. I've used it on white lesions after orthodontics, but it's basically, when I use it, I explain to the patients not to get rid of the white lesion. It's not an aesthetic treatment. It's not going to be a cosmetic fix. It's to prevent that lesion from developing decay. Now, have we seen some of those white lesions improve? Absolutely, we have. But it's for me, it's a completely different indication than what I would use icon for.
I agree with all of that, Dr. Miller. Beautiful
Yeah.
answer.
Thank you. Can Curodont be used on a lesion that's already been treated with SDF?
I can take this. I can
Yeah.
take this.
That's the one we just did. That's the one we just did. Sorry.
Yeah. Yes, it can. The biggest thing is you have to remember you're treating lesions that are demineralized. So if the lesion's already arrested, Curodont wouldn't be indicated for it. So you'd have to use your clinical judgment, and it won't remove the stain. So yes, so if the lesion, you're worried about progression and you want to treat that incipient lesion or the lesion that's been treated with SDF with Curodont, you absolutely can.
Great, thank you. Danielle Crandall wants to know, do you have to hold the sponge on the tooth for the entire 5 minutes or just paint it on the tooth and leave the tooth isolated after painting on the Curodont?
You just paint it on. We don't apply for 5 minutes. We paint it on, and as I said in that step, I've instructed my hygienist basically just to use it for 30 seconds, but there's no hard and fast time rule for that. The only thing is that the 5 minutes is just to keep the area isolated, but it's a pretty quick application. Once you see the area saturated, you've basically done your job.
This next one from Radhika Gowali, how many teeth can one application tube work on?
I use one applicator tip for up to three teeth.
Yeah, typically 1 to 3 lesions is what we're seeing used for, especially if you're doing that interproximal, probably 2, smaller, smooth surface, 3. But it's going to be patient dependent on the size of the lesion location.
Thank you. From Veronica Yu, are there studies showing the efficacy of Curodont versus something like silver diamine fluoride?
No, we don't have any studies in a direct comparison to SDF, but our studies show over a 90% success rate for stopping the progression. So, but no current studies against SDF.
From Emily Johnson, that brush looks challenging to use. Has a thinner, more rigid design that would be easier to independently insert interproximally been considered?
We always appreciate feedback when it comes to the design. So Dr. Miller, I can let you, if you want to say anything about using the applicator, you can give some tips and tricks, but we appreciate any feedback.
And well, you make a good point, because I found that in the beginning as well. And that's why we used, in the video, you'll see the use of the flat plastic instrument just to press it into the interproximal. So I normally just press the applicator, even on the smooth surfaces, I press it down with a flat plastic. It's not, it doesn't take much more time at all. But you make a good point. If the tip wasn't as soft as it is, perhaps we wouldn't have to use that at all. So Dara, there's something for you to go back with.
Yes, yes. But like Dr. Miller said, if you're just taking it and able to squeeze the sponge, whether it's with the applicator or a flat composite instrument, I like my barn part for the interproximal, that allows that sponge to release the liquid. So once you do it a couple times, I feel like you kind of get the hang of it.
Yeah, yeah, you do.
Thank you. From Janet Moore, does Curodont come without fluoride?
No, it does not. Not here in the US.
From Jayashri Srinivasan, case selection, depth of incipient caries that Curodont can remineralize?
E1 and E2 lesions. So E1 are in the outer enamel, outer half of the enamel. E2 extends into the inner half of the enamel. Anything that's reached the DEJ or further is not a candidate for Curodont.
I thought I could answer this next one, but I can't. Radhika Gowali is asking, how much is the MSRP currently? Thank you.
It's going to depend on, I don't have the most current one from Henry Schein, so I think we can definitely get back to you. But regardless, if you scan the QR code, I think it'll take you to the ordering site where you can get 15% off.
And this one from Nicole Gallegos, do you know if any insurances cover this code?
I personally don't know, and perhaps we can refer that question to Dara, but for me personally, I prefer to keep that out of the hands of insurance. I just, this is the same way that we do most adult fluoride treatments and make it patient responsibility. I just find it's a much quicker, easier conversation, and they either want to do it or they don't. And as I said, we've had very little, if any, pushback. But I don't know, are there any treatment codes that insurance are paying for hydroxyapatite remineralization?
Well, the code that you bring up, the D2991, Dr. Miller, is a very new code. It just became active in January. And if you've been in dentistry any length of time, you know that can take time for insurance companies to pick it up. We do see some insurances companies covering it, but with over 50,000 plans out there, that is a question that's hard to answer. So you'll just have to check with your individual insurance carriers and their plans.
This next question is similar. Are insurance companies paying for this procedure? From Patricia Wiley.
So we don't, at this point, it seems like there might be a couple that are jumping on board. We have not billed insurance for this yet.
Yeah, and like I said, we are seeing some that are covering it, but again, it's kind of all over the board. So it'd just be best to check the code that Dr. Miller mentioned, the D2991, with your insurance providers.
From Harley Williams, what is the shelf life?
2.5 years, 30 months.
Great,
and there's no
thank you.
special refrigeration. Just keep it on regular shelf.
And you've already given this code, but someone is asking again, Stephanie Lafon, what ADA code should be used for billing insurance?
That's D2991.
From Amber Lingle, is this something, okay, I think we just answered that one. We use SDF. Would this product replace SDF?
I can take it from Dr. Miller if you want me to.
Yeah, I mean, go ahead. Thank you.
Yeah. I mean, you have to think about the applications for SDF and Curodont. They're different. You're really focusing on those early incipient lesions with Curodont. It's non-staining, tasteless, typically, like Dr. Miller said, a one-time application. So for me, just from a clinical perspective, I think it's another tool in the toolbox. And so it's not replacing SDF for certain applications by any means for those cavitated lesions. But there's definitely an indication for Curodont with the early enamel lesions or those, ortho white spot lesions, things along those nature. Dr. Miller, is there anything you want to add on that for the SDF?
No, I think absolutely. I don't think it's a replacement. I think it is another tool in your toolbox. And I agree exactly with what you said.
Great. This next question from Danielle Crandall. I've seen people dip the sponge back into the liquid after pulling it out from the tube, but also heard you shouldn't do this. What is the correct application method?
I've never dipped it back into the applicator.
And it's not meant to. Once you plunge the applicator, the cylinders together, we say wait about 10 seconds for the sponge to become fully saturated. If you've ever tried to redip the sponge back into the reservoir, it's very hard to get back in, and it's not meant to.
Great. This one from Adriana Di Pasquale. What should we use to clean the tooth prior to applying the Curodont?
So, as explained earlier, most of ours have already been cleaned in hygiene just because we're coming in at the end of the hygiene visit. But, pumice, polishing paste, any of those, any technique that you would use to remove the pellicle layer is exactly what you could use for this.
From Jordan Balvich. So are you saying you can use it in pit and fissure decay?
I wouldn't use it in pit and fissure decay. I would use it in the pits and fissures for incipient lesions. So if it's an explorer detectable lesion, you get a stick, or if I use a diagnodent and you get a reading that would be indicative of the lesions extending beyond the enamel, I certainly wouldn't use it. And in the pits and fissures, actually, if I'm honest with you, I've only been using it there for the last 6 months because I wasn't even aware that you could use it in those areas. So that's been a new area for us to treat. And as long as there isn't an explorer detectable lesion, as long as it's not cavitated, you'd be absolutely fine using it. And if you want to confirm that with a diagnodent reading, no problem.
If caries are close to the pulp, is Curodont a good option? Would it cause any sensitivity?
It's not indicated for any lesion that extends into the dent, and that would definitely be a contraindication for using Curodont.
From Amit Shah, how do you explain your informed consent as far as it might not work, quote unquote?
Actually, we don't even get a patient. We haven't had patients sign an informed consent for Curodont. We do have a general hygiene informed consent. We basically just tell them, that there's a 90% success rate is what we've experienced in our practice. But like any other treatment modality, you can't guarantee success. So I think as long as you set the expectations correctly, I think you're not going to have a problem there.
Yeah,
From Stephanie LaFont. Oh, sorry, Dara.
Definitely, that's a great way to explain it.
Cool. From Stephanie LaFont, does Curodont help with white spots and demineralization?
It actually does. We've seen some improvement with white spots, but it's not a replacement for Icon, as I said earlier. I don't use it. If a patient comes to me and says, I don't like these white spots, how can we get rid of it? That, for me personally, would not be an indication for using Curodont. I have seen some improvement with it, but I don't use it for cosmetic treatments.
And it is safe to use around ortho brackets as well. I think that may have gotten cut off a little bit. But yeah, you can use it around ortho brackets safely. We haven't had any issues with affecting the bonding strength. So my recommendation, if you have that demineralization around the ortho bracket, treat it at the very first signs. Don't wait until they're out of ortho. We want to treat it at the earliest stages.
From this is the last question we have time for. Bradley Anderson, how can we guide ortho offices to do scaling for white spots? It's not a typical ortho procedure.
I'm not sure if I'm understanding the question, what he means by scaling for white spots.
Okay.
I'm not understanding it either, Dr. Miller.
I think what they might be referring to is how do we get ortho offices to offer this as a service or become compliant with using it, because as Dara said, you want to apply it as soon as you see the white lesion around the brackets. It's basically going to be up to Vivardis to market it to the orthodontists effectively so that they know, you know, that they would be the first people to see it and to start using it.
Yeah, and that's even how we train as well. In our trainings, we say it's absolutely a great procedure to do in the ortho chair, because you have to think, if your patients can come out of ortho with healthier teeth, it's a better experience for the patient overall. So I think that should be motivating enough for orthodontists to apply. But if they don't want to apply it in their chair, I think it's a great referral back to the general practitioner to treat.
Wow, well, thank you so much for a wonderful presentation. We have lots of questions that, of course, we didn't get to, but we are going to be responding to you via email. So we want to thank you for getting those questions in. This was just an amazing presentation. I want to thank you again, Dr. Miller and Dara, for a really great informative presentation and for answering so many of our questions. And we did record, again, today's webinar, and we're going to be emailing that recording out sometime in the next week, just a reminder. And we'd also appreciate your feedback via the survey that's going to pop up on your screens shortly. And with that, I want to say goodnight to everyone. Thank you again for joining us. Thank you again, Dr. Miller and Dara. That was really wonderful.